So what we're going to do now is we're going to ask Felicity and Alice to come up and talk to you about the research programme. Again, if you're going to ask questions, we'd love for you to use the app so that people who are joining us remotely can see the questions, can be part of the conversation and can see what's going on. So I'm looking at Andy now. Do we got a thumbs up? Okay, so ladies and gents, please would you welcome Felicity and Alice to the podium. Thank you very much.
Hello, good morning, everyone, and thank you again for having us here. It's been a fantastic weekend so far, and we're looking forward to all the activity we're involved with today. So this presentation really is to summarise what Alice and I have been trying to achieve over the last few years. And we're going to talk about symptom burden in PBC, and in particular, the evidence of managing fatigue in patients with PBC. We have been involved in quite a few studies now around exercise in liver disease and in specifically PBC. So we're just going to present some of that data and some of the work that is ongoing at the moment and sort of really try and summarise what we have learnt from those studies and how we're using them to kind of take forward. And we're currently applying for a grant, which is called Revitalise. And so we're going to be talking about the aims of that study and how we're taking our learning from previous research and trying to apply it for the future. And then at the end, we've just got a few questions that we'll be using something called Mentimeter. So it will have a QR code on the screen. So if you can use the screens around the room and the screen up here to just scan that QR code and answer the question. It's really, really useful because we're applying for NIHR grants and they're really interested in the patient voice. We want to make sure that any studies that we designed have the patient voice loud and clear within those studies. So all the feedback that you give us there is really going to help us make decisions about the method and the structure of the research study. So please, please, please do participate in those questions and then we can make sure that we tailor these studies to benefit you. I will now hand over to Alice, who's going to talk to us about fatigue.
The $1 million question, fatigue. Such an underrepresented symptom in terms of what we can do about it, but we know how much of an impact it has on our patients and their families and loved ones. And what we really want to do is try and deep dive into what fatigue is or what our understanding of it is, and then challenge the room to try and give us your interpretation of what you feel fatigue is to you. We've alluded to the fact that fatigue is very individualized and it looks different in everybody, which makes it hard as clinicians to be very prescriptive to say this will work for everyone because it looks different in everyone and it makes people feel different to the neighbor, to the other person that also has fatigue. Nice little liver here. Bringing it down to PBC. So when we actually think about splitting fatigue, as clinicians, we accept it in two forms, and that is central and peripheral. Has anyone in the room heard of that? Is it totally new, or so this sort of idea that we've got a central side of fatigue and a peripheral side of fatigue. What we do know is that debilitating refractory fatigue affects between sort of 40 and 80% of patients and is one of the most commonly reported symptoms of PBC. What makes it really challenging is that it doesn't necessarily correlate to liver disease severity. So just because you are extremely fatigued, it doesn't necessarily mean that your liver disease is very advanced, but it certainly can put those questions into people's minds. I'm suddenly very fatigued. Is my liver disease getting worse? But they haven't necessarily attributed it to a correlation there. But what we do know is that it has a significant impact on quality of life, and it has a significant impact on, good transplant-free survival in terms of quality. So if we deep dive then into sort of central and peripheral, the idea is that central side of things is more around memory disturbances, that sleep disturbance, reduced sleep quality, increased daytime sleepiness. So you're feeling okay, and then suddenly out of nowhere, you get very sort of foggy headed, feeling very sleepy. You can be concentrating one moment perhaps at work and then just thinking, oh my goodness, my battery is at 0. I just can't think. I can't find the words I need. I'm meant to be listening to somebody, and I honestly have no idea what they're saying to me. And they think that's to do with sort of central nervous system dysfunction. Compared to the other side of things where we've got that peripheral fatigue. So yesterday there was conversations around sort of, is it joint pain, muscle pain, in that body just feeling very, very flat. And what that can do is it actually can reduce your ability to participate in things. So you wanting to go out and do something, or your actual overall fitness. There's also some links that maybe the muscles don't clear out toxins as well as somebody that hasn't got PBC. We get this increase, have you heard of lactic acid, only getting a stitch or that burning in the muscles, so patients are more susceptible. And then also you're actually requiring a lot more recovery time. Okay, so it's not just, okay, I've done that and now I can move on to the next thing. It's about thinking about pacing. So what we do know is, do they intertwine? Do you have one without the other? Most people report an element of both, and that can be really challenging. Does one cause the other? Does one type of activity cause one over the other? So it can be really challenging, but what we do know is most of our patients present with an element of both. So the research that's out there then, so Newton and David Jones and colleagues had a little look at how we look in terms of that daytime sleepiness. So this particular study looked at 48 female patients against 48 sort of case match control individuals. And what they found was that despite sort of spending 30 minutes longer in bed, they had significant more what we call sleep latency. So that's the ability to drop off to sleep. So have you ever had that feeling in the room where you're really, really, really tired, just so tired, and you go to bed and you're like lying there awake, and it's so frustrating. You think, I'm so tired. I felt tired all day. All I've wanted to do is get into bed. I get into bed and you just cannot drop off. So despite having longer periods of time in bed, that sleep latency is a real problem. And actually 50% of patients with PBC compared to the controls reported that they had more daytime sleepiness using the Epworth Sleepiness Score. So these findings were actually objectively supported via accelerometer data. So we're trying to move more digitally. So, the sort of wristwatches that can accommodate for how well you're sleeping or for what your physical activity level is like. And again, notice that on average, people were sleeping 50% more in the day compared to healthy control patients. And therefore, unsurprisingly, this therefore linked with how they felt fatigued. So the more fatigued somebody was, the more daytime sleepiness they were having, the more fatigued they felt in general. But actually what they did notice is that the more fatigued they were, it didn't necessarily correlate with how well their sleep quality was. So if somebody's sleeping more, doesn't necessarily mean the quality of that sleep is better. So it's quite interesting to consider. And this was sort of backed up with sleep-wake profiles in terms of another Montagnese and colleagues looked at 74 patients and 79 healthy controls. And again, they had significant that sleep latency versus patients that with healthy controls that were able to drop off to sleep. They were feeling quite tired and they were able to get off to sleep compared to those patients with PBC. And something that was touched upon yesterday, actually, and it was that latency necessarily linked to pruritus. We did touch upon yesterday that on sort of the literature supports that patients' itchiness or that pruritus is worse at night. So again, is that contributing to that increased sleep latency, is that ability to drop off to sleep? Now, this hopefully is something that you're all familiar with or maybe have come across with your consultant. Again, some of the work by Professor David Jones looking at the TRACE approach. So it's really trying to see what can we do to improve that sleep hygiene, what good routines and good healthy habits can we get so that we can improve both sleep latency and also sleep quality. Now, some of those things you might think, well, that seems quite obvious, but we also know that in a busy life, it's not always that simple. But what we're recognizing that it is really important that we prioritize our patients, and we're having these conversations. As clinicians, we shouldn't be assuming that patients have these answers already. And it's about having those conversations and reminding individuals what they can do to try and help themselves. So some small things there around sleep hygiene, routine, trying to limit bright light, perhaps electronics, avoiding large meals. And again, everybody's different. So it's not going to be like, if you do all of these things, it's going to improve, but you might notice that some things are triggers for you. And then if we actually look deeper into the trace approach, it's about treating the treatable. Is there anything from other conditions or part of your disease that we can be treating to improve your sleep? Can we get rid of those sleep disturbances or any other issues around depression to try and get rid of the problems around sleep latency? Having that sympathy and that element and ownership and coping, rather than just saying it's part of your liver disease, which I think a lot of our patients hear, you know, that's just part and parcel of it. It's having that empathy and that listening ability as clinicians to ask the questions and have the conversations. And I think certainly we've learned that we might not always have all the answers, and, you know, we're developing research ideas to try and see what we can do to improve this, but it's just acknowledging that it's a real symptom for you in the room and what can we do, and to just listen. And it goes a really long way. So having that empathy and just sort of, rather than palming it off as, well, that's part of your disease, and sort of manage it, or the classic, well, you know, maybe just do a bit more or just do a bit less. And it's like, well, what does that actually mean? And how do I make that information useful to me? So looking more sort of at that peripheral side, well, what can we do then to try and improve that body joint pain or that muscle pain? What we have noticed, again, by, you know, sort of the familiar names here, so Hollingworth and again, Prof. Jones, they noticed that actually when we do sort of repeated exercise, it potentially can have a positive effect maybe on muscle ability, or what we call bioenergetics, that ability to flush out those nasty toxins. But they also notice it's that loss of capacity to recover. So it's needing time to have a paced program potentially, or the intensity of that program, does that need more work because patients are tiring quicker and they're taking longer to recover? So it's not saying that exercise potentially can't work. It's just saying, how do we make it work? And that's what we're still quite unclear on.
Brilliant. So thank you, Alice. So I think really we would, as we carry on, we just want to get a bit of a gauge of whether you have symptoms of fatigue. So this is your first question of quite a few today, but we've just got a couple of questions now and a few questions at the end. But yeah, if you could all just take out your phones and scan the QR code, then we can start tallying up. And it doesn't matter either way. You know, you might be sat here saying, I don't have symptoms of fatigue, and you know that just because we're talking about it doesn't mean you have to have them. But yeah, just for those whose eyesight can't read, it's very small print. The code is 68427860. That's 68427860. Just a couple more. The question here, and also just by the screens. Brilliant. Thank you, everyone. And thank you for your honesty with that. So really a really large percentage then of those who have answered the question that have symptoms of fatigue. And so my next question, apologies of getting up. This is our last question and then we'll move on. And then at the end, we've got a few questions, which might be better than to sort of stay near the screen. The next question then is, do you get asked about fatigue when you go to your clinic assessments?
Code for that.
Yeah, I'll just give you a second. And those at home as well, please do log in. Everyone's on Mentimeter now, so this is quicker. Brilliant. Oh, is it going to take over? The red, who's going to win, red or blue? How good are those clinicians? Oh. I can twist that now and say more than half of you. Good job, we can't name and shame, isn't it?
Yeah, we could.
Okay. So it's quite clear. It's a bit hit and miss, isn't it, about whether it's discussed. And that just brings me on to kind of the next slide here with me. And we do know, and that's, I mean, we've had a higher percentage of this room that have a prevalence of fatigue. And what we do know really is that the mechanisms of it, so what's causing that fatigue, is quite poorly understood. So we know the symptom burden is there, but what's kind of causing it and how we're managing it is not well understood at the moment. But we do accept that it's having a really high burden on your quality of life. And that's why it's really important that we tackle this and make it a research priority going forward. The national guidelines do state that fatigue should be assessed in PBC. So if you get to the end of your clinic appointment and you haven't been asked about it, you should be sort of saying, you know, you can ask them and say, would you like to ask me about my fatigue? I'd really like to have a discussion with you today about my fatigue. Okay. The problem is, I think, really, when it comes to it, we know from a very good PBC patient survey that was run by Robert that 44 to 43% of patients with fatigue were not asked. 45% of those were given no advice, and 35% told no treatment available, and 24% were given basic lifestyle or coping mechanism advice, which is really centered around that TRACE method that Alice was talking about earlier. And when I've talked to clinicians about this, really, it comes down to that kind of first point here of it's poorly understood. So I think really maybe that sometimes people avoid asking about it because there isn't a lot available at the moment that's really tangible. They can say, look, if you do this, it will really help with it. And so they kind of, I think, avoid it a little bit because doctors are really like to help people. They like to fix things. That's their job. And so when they're faced with something that they feel like they can't help with, it's something that makes them feel quite uncomfortable. And that's the exact words that have come out of some of the physicians that I've spoke to now. So they're really also really pleased that we're looking into this because they really do want to help you. So do ask about it, have an open conversation about it. The expectations of what they'll be able to say, it might be, you know, quite low in terms of actually, you know, you're not going to come out of that clinic appointment and someone can kind of magically click their fingers and make your fatigue better. But I still think it's important that you're having those conversations and thinking about whether it's getting worse or better, and if you've changed anything in your lifestyle and how that's helping you, and just keeping that discussion open because it's learning for everyone. So my last question is, what strategies help with your fatigue, if anything?
So with this one, you'll be able to just put free text in. So there'll be words that you can put in.
Yeah. It's really good. Really good. Loving the exercises at the forefront there. Nice and big. But some other ideas as well, thinking about what you're eating, how much rest you're having, pacing yourself, mindfulness, meditation, even, afternoon naps, really incorporating that into your rest, understanding your body, really, really good, trying to plan your activities. So it sounds like you've got a lot of kind of peer support in the room here of sharing your ideas and strategies of what you're doing, and remembering that what works for one person might not work for another, and that's okay as well. It's about trying to keep it that personalized approach. But these are some things that you can kind of look into and, really help start having an impact. Prior to this weekend, had you considered exercise as a treatment or a management strategy for your fatigue?
Not a trick question.
No, it's not a trick question at all. Good. So quite a lot of you saying like, yes, you had considered it, which is really good. So I'm just wondering whether people feel like confident then in doing it. Sort of they thought about it, but have they gone and done it? What do they do? What type of exercise works best? So these are all things that we can kind of discuss further, particularly in our focus group sessions this afternoon.
So just drawing our minds back then to treatment options and being in that clinic room and thinking, right, so I have fatigue, this is how it presents, what can we do about it? And that's where we really hit some stumbling blocks. So when we're thinking about medication and what medication potentially is out there for our PBC patients which have fatigue, sort of our common medications that you might be familiar with in terms of treatment, they all have a really great impact on fatigue, as you can see, supposedly. So that's not really an option for us, although holding your disease at bay, they have an excellent place, and I'm certainly not advocating not taking them. I'm just saying in terms of impact on fatigue, in terms of improvement, unfortunately there isn't that correlation, or it's not well understood at the moment. So that's kind of out for us. Bit contentious, in the past there has been some suggestion that maybe liver transplant could improve symptoms of fatigue, but actually the literature that is out there is suggesting that following transplantation, if your indication is fatigue alone, there isn't improvements. And so much so, certainly now at Birmingham Centre, the indication for fatigue, and I say this very carefully, the indication isn't strong enough to undergo such a major intervention, because the outcomes are just poor if that is your primary reason for transplantation. So transplant is also out. So what does that potentially leave us with? Some alternative options, but it's not just around the exercise. So yes, myself and Felicity have very much acknowledged that we feel exercise has a part to play, but it's how that intertwines with everything else in terms of potential sleep, health, psychology, mood, etc. So we like to think maybe it might help. And that is actually supported with some pilot data. So myself, Felicity, and fellow hepatology colleagues, including Dr. Palak Trivedi, Matthew Armstrong, a couple of our nurse specialists, Jennifer Hayden, and then one of our PT colleagues, Simon Derman, we took part in a small-scale study looking at home-based exercise in patients with fatigue in PBC. This is actually just the protocol. However, this weekend, you might, if you're interested, the actual results are now published in JHET reports. So look out, watch this space, go and see what we did there and what we found. But I'm going to talk you through it anyway. So moving on, essentially what we looked at is a 12-week intervention looking at patients with moderate to severe fatigue. And that was classified using the PBC 40, which I'm hopeful some of you have recognized before. It's a questionnaire with 40 questions, and there is a fatigue domain within there. And what we were looking for is any patient that scored 33 or above in the fatigue domain. They were eligible for our trial. Obviously, after medical screening, there's specific exclusion criteria, which I won't run through here, but you, of course, can go away and take a look at it. And the idea of that program was to provide individuals with resistance-based exercise that required no specialist equipment per se, that were easy and accessible, and ideally sort of moderately paced. So we wanted patients, anyone that sort of took part in our exercise class this morning, sort of that moderate pace where there was an intensity level there, but it wasn't absolutely exhausting, but you were also aware that you moved your body. And we had 3 visits, a baseline, 1 at 6 weeks and 1 at 12 weeks. Now, if you've been provided an exercise program on one day and then that's not reviewed for 6 weeks and it's a new skill to you, it might be how we're going to encourage that individual to stay on that program. So it was facilitated with telehealth calls. So we would call our patients virtually, sort of every 2 weeks to have those conversations about their program, which allowed us to either regress or progress it based on their confidence, how fatigued they were, their perceived efforts. The patients could also call us at any point. So although we had those structured 2 weekly telephone consultations, they could also make contact with us if they required. And what we found, which was great, was that there was a significant reduction in fatigue with our patients, and fatigue decreased in 27 of the 31 participants, with 26 of them meeting the primary outcome, which was greater than 5 points in the fatigue domain. And what was really interesting, of the sort of 31 patients that were included within this trial, by the end of the 12 weeks, 22 of them wouldn't have been eligible because their fatigue was below the threshold for accepting them into the trial. So we were very excited about that. However, there were small numbers. It was only observational. And really, we don't know what the sustained effects were for that because it was just a 12-week trial. So really more is required to understand why it worked and what other studies maybe could offer to try and blend together.
Brilliant. Thank you, Alice. So along the bottom there, you can see that as well as reducing fatigue, we also showed that we significantly improved physical function, sleep quality, anxiety and depression scores improved, as well as their overall quality of life. But as Alice mentioned there, we didn't really know what the sustained effect was because it was only over that 12-week period. And if that patient then stopped seeing physio, is it something that they would continue to do, and would it have the same effect? And we've utilised this kind of methodology in other studies with patients with liver disease as well, with the same kind of feeling that we get these great results at 6 and 12 weeks, but we're living lifelong with this disease, and we want to make sure that patients are able to manage their fatigue without such an intense input all of the time. And so this is another study, and I'll add that this is in patients who are undergoing a liver transplant, but it is something that Alice and I are heavily involved with. So I'm the PI on the study, and Alice actually is treating the patients and running the study on the ground floor. So this is called the ExaLT trial, and it's called a home-based exercise and motivational program. And that's a really, really key thing here. So we combined an intervention where they get aerobic and a resistance-based exercise, but we have gone and collaborated with behavioral psychologists who have then trained our physiotherapists up in behavioral psychology techniques, so that when we're delivering the exercise, we're not just saying, I think probably a lot of people I've kind of spoken to over the weekend, sometimes you go and see a physio, you're kind of given your exercises to do, and then that's kind of it. And obviously everything is a little bit more nuanced than that, and you've got to get to know the individual a little bit more and work out what their motivators are and what their barriers are, and actually having a little bit of behavioral psychology mixed in with exercise, we're hoping is going to have a little bit more of an effect on how the patient then carries on. We've talked a lot about the kind of undulating kind of state that we get with chronic disease, and sometimes things are going okay and other times they're really not okay, and how do we maintain our lifestyle changes through those processes? So this study is actually, we're delivering it for up to 1 year pre-transplant. So we get a full 12 months worth of data, and then they get 6 months of rehab after their transplant. They can be transplanted at any time. So we just move past, that's a little bit more understandable here. So they get the transplant, then they have 6 months of rehab, but they might be transplanted after their visit 1 or visit 2. We've got 272 patients in this study right now. So really, really good. Patients are very, very engaged with it. And the feedback so far from patients has been phenomenal. Let's hope that translates into data, because that's what the stakeholders like to see is the data. But certainly from patient perspective, we're getting a lot of positive feedback. And even those patients, we've run PPI groups, afterwards, and they've come and presented and talked about their experience in the study. And actually 6 months and 1 year post-transplant, they're still saying, they get still periods of low mood. They still have things that they come across that they have to manage in their daily life, but they utilize the principles that they got taught in this study to manage that. And that is really what we're trying to aim for. So we want to make sure that the patients are supported, but also empowered and given the confidence and the competence to kind of deal with that undulating pathway going forward. And this is just like a little bit of information on kind of how we decide exercise prescription for these patients. So we will, there's something called the Liver Frailty Index, which combines chair stands, a balance test, and hand grip tests, and they get a score, and we kind of then adapt people onto that level. So the way the aerobic and resistance training program works within the ExaLT trial is they have 10 levels of aerobic exercise, and that could be walking, jogging, swimming, cycling, let's say swimming, rowing, any kind of form of aerobic exercise. It's really important to us that patients have choice. If I was told to do 10 exercises for the next 3 months, I guarantee you after about 2-3 weeks, I would have given up on them because it's just boring. So we need to make sure that patients are able to have choice, able to, some people like aerobic exercise, some people hate it, and you need to be able to kind of choose what you want to do if you're going to stick with it. And then we have resistance-based exercise programs. That's very similar to what Alice was talking about in the ExciTED study. So very much body weight exercises. We try and avoid using equipment. The only thing we do add in is TheraBands because they're really nice, easy thing to add in that we can supply through the NHS and add a little bit of load when we get to the kind of higher levels in resistance training, because that's also important to us. We deal with a lot of patients that are quite low level exercise, but as they get better and they progress, we still want to be able to support them later on. And we also have patients who actually, were really fit and active before. And yes, they might be still considered to be quite fit and active, but they're a lot less than what they were before. And I think it's really important to acknowledge those people as well, because it's about kind of what you're used to, what your normal is, rather than just kind of everyone who's at the lower end of it. So we kind of look at that between, there's a Duke Activity Status Index, which is a questionnaire about aerobic activity as well. So between these two kind of, they're very short assessments, but they give us a kind of a snapshot of where the patient's at. And then along with kind of, it's almost like an interview really, isn't it? Of like how the patient is, what their support network's like, what are their work commitments, what is the day in the life of that patient, and what barriers do they face, and how are we going to work around those and with the patient to kind of progress them forward. And so far we're seeing really, really good results with that. So the other kind of aspect of it, and this kind of links with what we've talked about in the ExciTED study, but also thinking about, their sleep, how is that being impacted at the moment? Also considering stigmatism, patients with liver disease talk to us a lot about this and how sometimes they find it quite difficult to maybe even like approach a gym session, their local gyms, and kind of say, I've got liver disease and this is what I want to do, but not knowing how people are going to react to that, how much they understand about PBC, and how much they understand about the impact of exercise, how accessible is the program that we're giving to them, and also bearing in mind any comorbidities, symptom burden, hospital admissions. People can still get other symptoms of other diseases. We've talked, a lot of people have come to us today with, musculoskeletal problems. So, sometimes people have got, a knee that's not quite right or a shoulder that's not quite right. And it's thinking about how we're working around that as well. And I guess, so the key kind of message I'm talking about here is that we're making sure that everything is personalized to that individual. We believe that that is critical. So we can provide generic advice, and that is good to a certain extent. But if you're really, really going to engage a patient long term and think about, how we can support them throughout the whole process of their condition, then we need to make sure it's personalized. We need to make sure the exercise program is responsive and adaptive. So that means that, if they've started an exercise program and it's getting easier because they're getting better, then we need to be making sure that we build that up. But equally, if they've gone through one of the, the lower points in their pathway, then we need to be able to adapt the exercise program to that and be really kind of supporting them with that. Like one of our patients is, he said he went through some really, really tough times, but he really, really appreciated that it was okay to change his exercise program. It was okay to make the exercises easier. It didn't mean he needed to stop everything and lose everything that he'd done, and appreciating that there are times like that and we can just build back up again. So we believe that behaviour intervention is crucial for long-term change, and that what we probably maybe enjoy most about everything is the rapport that we build with our patients and the rapport that they build with us, and that is invaluable throughout the pathway. So this is just some of the feedback that we've had from both Excited Study and ExaLT. So doing the exercises made me feel calmer and helped me manage my anxiety. Physiotherapy gave me the confidence to get back to horse riding and yoga. I wasn't as anxious about my care. Physio has given me the confidence to do more. I'm now enrolled on a night course. Having the consistency of seeing the physios while I was unwell made me feel at ease. And I think physio should be compulsory for everyone with liver disease. It was like, yes, definitely. But I think what I really take from all of that, it's not really from us. It's not necessarily as though we want to see it replicated in results, but it's not data-driven results. It's about how we're impacting on patients' lives. And that's really, really important to us. So on to our next adventure. We are now planning a grant application. It's gone to the NIHR, the RFPB, so Research for Patient Benefit pathway. And there are 2 stages to that application process. So stage 1 and stage 2. It takes a long time to go through. So we submitted stage 1 in April, and we heard in July that we've got through stage 1. Yay. So we are, thank you. We are now heading towards our submission of stage 2, which will be in October. And that's with our research question that it's very long-winded. I probably need to adapt it. Does a physiotherapy-led home-based exercise program and motivation program, individualized and adapted according to patients' perceived fatigue, reduce fatigue in patient with cholestatic liver disease? So we're running this with both PBC and PSC. And the plan for this really, if anyone was around yesterday and kind of listened to the role of physio, we're still trying to, apply those core components of physical, psychosocial, and then medical context. And then utilizing all those things that Alice talked about in terms of, it's not just about exercise, but it's also the well-being of the patient, thinking about everything else that's going on with them in terms of fatigue, sleep, energy expenditure, and making sure we're being holistic with their approach. So the idea that we will have a visit naught again with a 2-week kind of lead up to it, and that's just to make sure that fatigue levels are stable. And then at visit 1, they'll be randomized to either the group 1 or group 2, with group 1 being the intervention. So this will be kind of a similar home-based exercise program to ExaLT, along with the behavioral psychology, but we're also adding within the behavioral psychology mechanisms by which we can identify and regulate symptoms of fatigue, and for the patient to learn kind of how to do that process. We will follow it up with the virtual calls. We've always had really, really good feedback on that. But as you can see, we kind of start with 2 at the between 0 and 6 weeks, and then just 1 between 6 and 12 weeks, because we usually find by this point the patients are more up and running. And then the intervention stops at 12 weeks, but we have another telehealth call at 18 weeks. It's like a check-in. And then we're still going to look at data at 24 weeks. And that's so that we can really kind of see whether we are making long-term changes. We're limited by funding. Otherwise, I would want to go even further than 24 weeks. But currently, we're capped at 500K, and you'll be amazed at how much everything costs in a research study. That hopefully will give us an indication as to kind of how that we have getting some kind of sustained effect on it. So this is your chance to help us decide how we fine-tune this study. So there's a series of questions now. I think there's maybe 4, isn't there? So if you do feel you want to stay closer to a screen, please do so. But would you consider participating in an exercise study to manage symptoms of fatigue, first of all?
The other thing to bear in mind is there are just a few questions here, and as you guys know, there are focus groups specifically targeted to this trial this afternoon. So just because the question might not have appeared here, if you've had any inspirational thoughts or you think there's feedback, please,
Would like,
yeah, pardon.
just like to be
Or
involved.
just like to be involved, yeah, just and find out more. Just come and find one of the focus groups, and we'd really, really be glad for your feedback and support.
Brilliant, good. So the majority of you are saying yes, which is always good to see. I'm really interested in the no and not sure as well as to why that might be. And if if you don't have symptoms of fatigue, that's fine. But we'd also want to understand, because if we're running a study, we always look at kind of, the big question is, are you going to recruit patients to the study? I mean, that's vital, isn't it, to the study? And so if patients are not happy to join it, then it's really good to know why they might not want to join it, whether it's something particularly about exercise, whether it's something about the timing of the visits or how often they might come to the hospital or the cost of it. So all of these questions are really, really important and useful for us to know, because if we can make any changes to the protocol that enables those, then that's really useful. Yes.
I'm very active, and my issue is that I can't do what I used to do, but I'm still very active. Walk, swim, bike, you know what I mean? Run by the playground with children in school. But my issue is, even like last night, I hit the sort of brick wall about 5:30 last night, and I feel I actually get nauseous, I get sick, and I have to go and sleep. And so when you're talking about doing exercise, I'm doing exercise. I do resistant exercise. And when I do yoga, I do things that keep me healthy. I do my gardening. My issue is that I can't do what I used to do, and that fatigue is physical. And someone said yesterday about feeling dizzy, and somebody explained that it's not that you're dizzy, it's that you get woozy with the head fog. And I thought, that's I could be doing anything, and then all of a sudden I just get this, and my body literally, I feel as if it's like you've got sort of brain fog. You feel as if you're just getting pulled to the earth. Everything, and the nausea. So I'm thinking, the last thing I want to do when I go and do my gardening, I go and do a walk, and when my body hits that wall, I'm like, I can't go and exercise. And it's not because I'm not inactive. So how, and
Yeah, absolutely. And I think that really comes to the holistic component of it. Which question? Sorry. Oh, this question.
can you,
I think,
can
sorry.
you please, yeah.
So she's just saying that she's quite active anyway. But she still finds that she's hitting that kind of that fog, that brick wall, despite kind of doing all of that. I think, was that correctly summarized? Yeah. Yeah. From it, yeah.
It's not, sorry, it's not just that my body feels heavy. It feels like I've got a magnetic pull to the earth.
Yeah, sure.
And it's not just that, it's the fact that physically I feel as if I'm going to vomit because I'm so tired.
Yeah, sure. And
And
we certainly have people, don't we, who are actually, quite active. And the study's not really about making someone from inactive to active. It's about how we utilize exercise and behavioral psychology to help patients manage fatigue. And so if you're already active, great, I'd have you on board. But it would be looking at kind of maybe tailoring that a little bit better, trying to unpick some of that kind of routine and working on maybe other elements within kind of the holistic pathway of as to how we would look at that and seeing whether that had an effect. And if it didn't have an effect, then fine, it doesn't have an effect. But I wouldn't say that your participation in the study is any less valuable than someone who has been inactive and then started participating in exercise. I don't know if you've got anything to add to that, but
absolutely. Just just echo what Felicity said, sometimes it's around pacing, and breaking down the sort of psychology of, this is what I used to be able to do, and now I am only able to do this. And, before you were diagnosed with PBC or before you went down this pathway, you were that individual, and now you're sort of somebody with PBC, and that can be, a really big thing to get your mind round, and it can be really hard to let go of, well, this is what I used to be capable of, and now I can't. And part of you trying to keep up with what you could do before, and actually, inevitably, what that's causing is actually more long-term sort of problems in terms of fatigue management or physical symptoms. So I would certainly say it wouldn't be you need to stop what you're doing. It's how can we pace it? How can we empower you? How can we make your quality of life better while still enjoying the things that you enjoy? So I certainly wouldn't perceive this study as only people that are inactive. It's for any level of activity, and that's our role together as an MDT with a holistic approach to make sure that we get it right in terms of tailoring what's appropriate and individualized for you.
Perfect. So this is about how we provide information as part of the study. Yeah, it's really interesting. Thank you, everyone. Really helpful. We'll just move on to the next question if everyone's had time to do that one. I can't find the mouse. There we are. Brilliant. Thank you, everyone. That's really good. And one last question for us is around kind of when you're coming for study visits at your local hospital or at your hospital where you go for PBC specialist centre. Yes, these will be weekdays. Yeah.
Looking good for my working pattern, guys. 11 till 3. You.
Definitely one evening a week
I
though.
know, 1 evening a week. 9 o'clock.
Good. So we're probably looking at a spread across the day, but then having maybe an evening a week of appointments that we can have an option for patients for. That's great. Thank you very much. So just to summarize then, thank you very much for having us today. Hopefully we've given you some insight into the journey that we are on and where we're hoping to go in the future. We would really, really value your input for more in-depth discussions like, the questions that were raised then is fantastic to be able to talk it through, and it will really give us some, really reflective thoughts on the way home to think how we're going to adapt the intervention and the method and how the study is set up. So please do join us at either 12 o'clock or 1:30 in the Teviot room to discuss further. Thank you, everyone.